Hello, everyone. Thank you for joining us today for this webinar, which will share details about the program that received the 2017 Future of Population Health Award. I am Margie Beaudry, Director of Performance Improvement Services at the Public Health Foundation. And before we get started, I just want to go over a few housekeeping items. All of your lines are currently muted. If you're using your phone, please choose the phone call option and enter your audio PIN, which is found in the audio panel. If you're using a microphone, please choose the computer audio option. The slides we're using today are available for download in the handout section of your control panel. Please use the questions panel to ask questions and to submit comments throughout the webinar, and we will be able to field questions after we hear from our presenters. This webinar is being recorded and will be archived. The archive will be made available following the webinar. So, Public Health Foundation specializes in mapping the drivers of change, building sustainable solutions, and helping communities to execute and measure the impact of change initiatives to improve the public's health. As you well know, solving health challenges is increasingly collaborative, requiring cross-sector partnerships that work on shared ownership of solutions to address the social determinants of health. For a number of years, we have seen a shift in how hospitals, health systems, governmental agencies, and community-based organizations address health issues that are impacting their communities. In large cities and small towns, collaboration among partners has become the way that big challenges have become shared successes. This often requires individuals and organizations to step outside of their comfort zones. After working with these diverse collaborators for decades, we have been fostering, observing, and celebrating groundbreaking practices to improve health outcomes. There is so much we can learn from these organizations that are leading successful, innovative work. The Public Health Foundation created the Future of Population Health Award to recognize exemplary practice by hospitals and health systems that are collaborating with governmental agencies and other community partners on successful health improvement strategies. We want to encourage hospitals and health systems to address the upstream causes of population health challenges outside the hospital walls and to celebrate innovative, ambitious, and impactful local partnerships that emerge from those efforts. The Future of Population Health Award highlights these achievements and the brilliant leaders and organizations that are using these approaches to transform the health of their communities for a better tomorrow. The challenge faced by this year's awardees is that the major medical center in the community was observing a vicious cycle in which homeless hospital patients who were ready for discharge had no stable, safe place to go and no coordinated access to support services to continue their rehabilitation. To tell us about their experience, I would like to now introduce our speakers from the University of Vermont Medical Center in Burlington, Vermont. Stephen Leffler, Chief Population Health and Quality Officer, and Penrose Jackson, Director of the Community Health Improvement. And with that, I will turn it over to Dr. Leffler.
Thank you, Margie. Let me see if I could. So I wanted to give a little background in terms of how we made this decision. And I think the most interesting part of this background is that Vermont, for all its beauty and everything, actually has a significant homeless problem. And while it's a relatively small number of individuals, because we're a small state, we rank quite high in the country in terms of per capita homeless. We have very, very few rental properties, and our numbers of chronically homeless have been stagnant for quite a number of years. At one point, the state was giving out motel vouchers to patients, but then that was costing the state so much money, they really chose to reel that in and stop spending so much money. And interestingly, in the 2013 Community Health Needs Assessment, housing was ranked #1. And we have a committee here that focuses on the CHNA and makes some investments. And in 13, we said, we don't really see homelessness as our issue. We're going to leave that to other people who better handle it. We're a hospital. But in 16, we really felt like it's time to address this. It's it's time to really start working on this issue. So we with a bunch of partners, looked at Harbor Place, which is an old motel in Shelburne, Vermont, that was able to be purchased to provide emergency housing wraparound case management services. I'm going to transition to Penrose now to tell you exactly what we did and what the outcomes were.
Okay, so as Steve said, we had a bunch of partners. Community Health Centers of Burlington is our only federally qualified health center. Champlain Housing Trust, I'll end with them actually. United Way of Northwest Vermont, Howard Center, which is our designated mental health agency, and as Margie noted in the beginning, the Vermont Agency of Human Services, their division for children and families. Champlain Housing Trust actually came to us to talk about possibly investing in housing for our own employees. And we declined that, but we kept up the conversation. They are our only regional housing trust. They have a fabulous track record. And the previous board retreat, they had actually settled on looking at reducing homelessness in the area. They had not really taken that on as a specific challenge or goal prior to that. So as we continued to talk with them about possibilities for what could help us and help our employees, we started to reflect on the fact that we had many overstays, people that were here long after they were really ready for discharge, but couldn't be discharged safely back to a tent or living outdoors, that they had wounds that needed to be checked on or other needs that no longer needed to be accommodated in the inpatient setting, but they weren't ready to be really on their own. And so we, Steve mentioned, we worked with them, with Champlain Housing Trust, to look first at Harbor Place, and we showed you the slide of that earlier. So the first thing we did was just buy bed nights. And as this slide shows, as of July 10th of this year, we provided nearly 3,000 bed nights for nearly 200 patients at a cost of about $79,000. And if anybody on the phone has looked at healthcare costs lately, you can't get that many bed nights in a hospital for that little bit of money. So that was really telling us that that it was the right thing to do, and it was cost effective for us. We should know that this is incomplete for this year. It is only as of July 10th, and it continues to change as each year passes. So what impact did it actually have on the people that we housed? This slide shows the cost. The tall bar in the middle is the cost of health care for these individuals in the 0 to 60 days prior to their staying at Harbor Place. We should note that in this case, there is a precipitating event. There is a hospitalization, and hospitalizations, as we all know too well, are expensive. But even discounting that hospitalization bar, if you look before and after, you could see that overall the costs have declined. And when you get into the 91 to 100 day, 21 post-discharge, it's really less than a third of what they had seen in that same period of time prior to their hospitalization. We compared the utilization and direct costs for another group of 147 patients, and this is what we saw. This also includes both inpatient and emergency department numbers. It does not include utilization of primary care, and that's something because we have multiple providers and privacy laws, we haven't been able to really research that. But frankly, we're hopeful that looking at this, that we would actually see an increase in primary care. And this is just another way of looking at it, cost per visit before and after the stay. Surprisingly, even though their utilization was higher in the 0 to 90, it starts to decline at the 0 to 60, and you can see that it stays significantly lower post their time at Harbor Place. And the expansion, we now move back to Steve.
Thanks, Penrose. And so what I want to let people know is that this first attempt where we basically purchased some bed nights for people who were having trouble discharging really emboldened us to start thinking bigger about housing. We were able to collect some data, and it looked like it was more than just housing them. It was probably the wraparound services. It was probably getting social worker there and case management and having them in a safe place. I should let people know that I'm an emergency physician, and I took care of a couple of people in the ED that had been discharged to Harbor Place and would come in with a problem that a month before they'd have to get admitted for, and they'd say, no, I have a place to go back to tonight, and the VNA can come visit me in the morning. So having a location where they could go back to that was safe and secure, where they keep their medicines in a refrigerator potentially, where we knew we could find them the next day, allowed them to go home from the ED instead of getting readmitted or admitted again. So we started thinking a little bigger about the issue, and were there other opportunities to grow this? So the second thing that we worked on with our partners was something called Beacon Apartments. So we partnered with the Champlain Housing Trust, the Burlington Housing Authority, Safe Harbor Homeless Health Care, which would provide case management health services, and there'd be someone there at the site 24/7. And I think the really novel thing about this is Chittenden County did a homeless survey, and they risk scored every person who they found that was homeless. I think they identified about 200 people. It's in that range of homeless people, and they risk scored them in terms of who were the most likely to die from not having safe, secure housing. And then we used that list to put 19 people into Beacon Apartments. Sorry, let me go back. And so what we did was we took the people at highest risk for death from homelessness and put them there, and we made it low barrier housing. We put housing first. You could go there if you were still drinking or using drugs or whatever. You had to be good to your neighbors and not violent, but otherwise we put people there. And we had amazing success. We were able to show very significant healthcare savings for this population as well. I will tell you that there has been some small amount of turnover, and we do see it's critical to have permanent case management there. And this year we just moved those dollars to a regular operating expense for the hospital. Excuse me. The savings has been enough that we can show that spending $100,000 for case management is a good investment. And we're seeing return on that. These people mostly have Medicaid or no insurance, so keeping them out of the hospital, that $100,000 is a good investment. So you can see that Harbor Place is very short-term housing, up to a couple weeks. Beacon Apartments is permanent housing for 19 people who have very significant health issues and were underhoused, or mostly they all had no housing. And now our middle place to round out our full spectrum is we have Bel Air. So Bel Air is something that we just worked on with similar partners. We paid out of our own funds $1.6 million to purchase and renovate this motel, and we've pledged to cover operating costs for the next 3 years. The tenants in the building are former patients or recent patients who experience being marginally homed or homeless. So they basically have housing that doesn't meet their healthcare needs, is the way I like to think about it. 3 of the apartments are designated for medical respite, where you'll go there and get certain issues that you need. You might be there up to 6 months, and then either graduate to one of the permanent apartments, or ideally go back to the home that you had that now will be able, as you're more healthy, will be able to meet your health needs. The remaining 5 apartments will be filled by people, as we said, identified by community organizations, most in need. So the Bel Air is just up and running. We've been able to put some people there that were very, very hard to place from the hospital, but can go there because the medical respite allows them to get more care than they could get for a longer period of time than they can get at Harbor Place, but they may not need permanent housing like they would need from Beacon. So, we have, like I said, short-term, medium-term, and long-term housing, and we're very, very diligently tracking the money that we're investing, and this population has allowed us to track their healthcare expenditures going forward, looking retrospectively and prospectively to show that it is a good investment as we're going forward. People may be aware that Vermont is got an all-payer waiver with the federal government, and starting in 2018, the hospital that Penrose and I work at, the medical center, the University of Vermont Medical Center, has more than 30% of our revenue under capitation. So projects like this start to really make a difference, and if you can show success and show a good return on investment, it allows you to grow the programs. So I'll stop there. I'm sorry, I got one more slide. And we have something called the Community Health Investment Committee. I want to just show some other areas we've invested in housing. So you can see there's 5 different programs here, everything from a warming shelter, because it gets very cold here in the winter, to Spectrum, which is a program for underhoused or marginally housed youth. It helps them get skills to live independently. A new place, we put $50,000 in 17, addresses the root causes of homelessness and helps individuals build a strong foundation, helps them get job retraining, case management to help get the other life back in line. So you can see here we have once again, we're investing with our community partners in trying to improve the housing situation for marginally or underhoused people in our region. And with that, I do think now I'll stop for questions.
Wonderful presentation. I want to thank our presenters. We're ready to take some questions, and we do have some in the queue. So I'm going to let Janelle read them, and I'll let our panelists respond.
Awesome. Thank you, Margie. The first question is, what was the source or sources of funding for the 2,691 bed nights?
This is Penrose, so I can answer that. So our case management team actually looked at that and realized, as I mentioned earlier, that the overstays were a significant problem for us. People didn't need to be here, could be back in the community, but we needed to discharge them safely. So they figured out the first year and said, well, what if we buy a specific number of bed nights, and will that make the pro forma on the motel work? And as if by magic, it did. And I think they actually were they estimated pretty accurately. They were pretty close to the real number that were actually used.
And just to add to Penrose's comment, we're the only tertiary care center in Vermont. And so when we have beds that we can't use to accept transfers, that's a significant issue for our region. And so to get people out of the hospital who no longer needed to be here and be able to use those beds for patients who needed to be transferred in made good sense all the way around. And so we basically took those dollars out of operating dollars in that first year and guaranteed we'd purchase a certain number of nights, and we were confident that those nights would pay for themselves by bringing in other patients who we might otherwise have to say decline to accept.
Great, thank you so much. Kind of in the same vein of that question is, what was the source of funding for the motel purchase and renovation?
So Vermont has a very complicated model of hospital budgets, and we have something called, we're capped for patient revenue. And if you exceed that cap, you have to pay the money back to the state, even if you've been busier. It's a very interesting system. I'll leave it at that. And so in 15, the medical center hospital was the University of Vermont Medical Center was very busy. And so we exceeded our revenue cap. And because we were working towards a capitation model, we asked our regulator to let us use some of those dollars to get us ready for capitation and make some investments in our community. So we were allowed to put some dollars into homelessness, some dollars into mental health, and some dollars into substance abuse. And so those dollars came from our patient revenue overage in 2015.
And I just wanted to comment that when we were given the opportunity to address this unexpected revenues, I was amazingly proud and gratified of the medical center, because we didn't have to go out into the community and say, oh my goodness, we've got to invest money, what do we invest in? That we knew from our experience and understanding our own community through the community health needs assessment, and also our relationships with so many community partners, where there were places that we could make valuable investments that would really start to move other needles.
Awesome, thank you both. We have a few more, which is questions. So the next one is still in the funding vein. Would it be correct to say that the reason why this innovation can be funded is because there's an unrestricted capitated fund pool?
I wouldn't say we have an unrestricted capitation. I mean, the way I would think about it is that we are on a journey towards having capitation, and we're working hard to have 80% or more of our revenue be under capitation. That's the direction that we're heading. Right now we're at 30%, and as you get to between 25 and 30%, it allows you to start thinking about things differently. Cost avoidance becomes critical. That's how you start to make more and more of your margin. For many years, we've been investing a small part of our margin, about $1 million a year, so 2% or so, 2.5%, in our community. Through the Community Health Needs Assessment, we would pick prioritized lists, and then we have a committee called the Community Health Investment Committee that would invest dollars. So for many years, we've strategically used that $1 million to make targeted investments. As we move to capitation, I think there'll be more dollars available, but really most of this, except for the last one, that hotel we just purchased, all came out of the Community Health Investment Committee.
Thank you. The next question is, were community health workers on your case management team?
No. So we don't have community health workers yet. I put them in the budget every year and keep trying. But the case managers that work out of the Safe Harbor Clinic probably could fill that role if we were going to define it that way. They help the people that they're serving with a number of needs, everything from food and clothing to maintaining their shelter. So, and then they get them referred into appropriate mental health and other medical needs. So we don't have community health workers. There actually are very few in the state, but we, I think, are more than meeting the work that a community health worker would do with other supports.
Great, thank you. The next question is, what type of screening process do you use? Specifically, how do you define high-need discharge patients?
Basically, our case managers know who's going to be difficult to place, either because they have care needs, or they have poor insurance, or they have a long commute to the hospital. So some recent examples, we've had people discharged to Harbor View because they live 4 hours from the hospital. They live so far away, and they have a number of recurring appointments over the next week or so. They're not going to be able to travel back and forth, and they don't have resources to stay in a hotel. So we put them in Harbor View for 8 or 9 days and let them get their appointments done. We've had people go there who couldn't make it upstairs to the second floor for their housing, either until they had a better mechanism to get upstairs, until they healed enough to get that done. We've had a number of homeless people go there while they're still convalescing from their illness, and then ideally, while they're there, caseworkers can help them get into more secure housing. And we've occasionally had people who rotate in and out of there a couple times until that gets established. But people coming from the hospital, it's our case management team that determines who would be able to go there with consultation from the medical providers. But for Beacon and Bel Air, it's in partnership with our community, who knows who the most needy homeless people are, who have the greatest potential medical needs from those surveys they've done.
Thank you. Let's see. So we have many questions rolling in, so thank you all for sending all of your questions. The next one is similar, I think. What are your guidelines for patient discharge from the apartment housing?
So the 19 unit apartment, they can live there for the rest of their lives. So there have been a couple of people that have been asked to leave because of behavioral or other issues. I believe there was a domestic abuse issue on one of them. But they're given as many supports as they can possibly be given in order to have a successful housing. I do want to note that I have heard, and I haven't, maybe it's an urban legend, but I've heard that a man and a woman who had been at Beacon Apartments are now one of the permanent housing apartments as a couple at Bel Air, but I don't have that validated.
Great. Thank you. Is there a specific process to determine who gets housing and who doesn't? Is it based only on the risk score?
For the permanent housing to this point, it's really been the risk score. For the short-term housing, it's really people whose current housing, whatever it may be, doesn't meet their healthcare needs, is the way I like to think of it. And we're still sorting, Bel Air is so new, we're still working our way through it, but those are typically people who've been stuck in the hospital for some long period of time because they have a health issue that won't let them leave, and the 3 respite beds at Bel Air will allow them to get the care they need out of the hospital.
Great, thank you. The next one is 2 of our top needs for our CHNA were mental health and diabetes. Could you give any insight to how this initiative would relate to these issues?
I think it definitely.
I'll start and I'll let Penrose jump in. As I recall, when they did the homeless project with the screening, 70% of the people had multiple chronic health conditions, and I want to say that wasn't it like 50 or 60% Penrose had mental health as one of their main issues that was contributing to their overall health and homelessness?
Yeah, and I think on intake, the director there thought probably it was closer to 90% had some kind of traumatic brain problem injury. So, and so the vulnerability index measures it, and I'm forgetting the question. What was the question again?
All right, it was, so with the CHNA identified the 2 top needs were mental health and diabetes. So could you give any insight to how this initiative could relate to those issues?
So certainly, so for both mental health, we didn't identify diabetes in our CHNA specifically, do talk about access to healthy food as kind of the side door into that. But as we mentioned, there's significant casework, which is both it's behavioral health, physical health, whatever people need, they get supports. And as Steve mentioned, these are pretty complicated, sick people. And as we showed from the numbers, their cost of their inpatient and emergency health care has gone down. And as I opined, and again, it hasn't been substantiated, we believe that that's likely addressed in some part by an increase in their use of preventive care and primary care.
Thank you. Let's see. Could you describe the greatest challenges you faced when implementing this intervention?
Well, there's a little bit of NIMBYism, and that happens everywhere. There were some challenges in Shelburne that with Harbor Place that Steve can speak to more than I, but it is a motel and people are coming and going, and there can be some challenges. With Beacon Apartments, interestingly, it was handled somewhat differently in terms of engaging the neighborhood prior to opening the facility, and the neighbors there actually welcomed people because they thought it would be more consistently managed and overseen than had been with the motel that had been there before. There were some issues early on with the police feeling that they were being called to the apartment building, but subsequently they've really worked it out with the tenants, and they go meet with them with no walkie-talkies and no weapons, and just kind of neighborhood watch, officer-friendly kind of things, and it's really improved things. And they've really come to see that they're partners in keeping everyone safe at the apartment building and in keeping the neighborhood safe.
So I will say that we've gotten smarter as we've gone along. And so the first place that we talked about, Harborview, there were people in Shelburne that were unhappy with that and felt that it was no longer a motel, even though it's still registered as a hotel and you buy nights. And so they tried to get it shut down based on zoning. And we had to go in front of the zoning board of Shelburne, Vermont, to discuss what we were doing, why we were doing it, and why we did feel that we were purchasing nights and not owning a medical respite house. And there are some people who stayed in there some nights who don't have medical issues. We don't purchase all the nights. And so we were ultimately successful with that, but we learned a lot from that. And so with Beacon and Bel Air, we've gone out to the community ahead of time, had meetings, met with everybody to have discussions about what we were trying to do, why we were doing it, who they could call if there were problems. And those have gone much smoother. So if you are thinking about doing this, I think it's really important to involve the community early and hear their issues.
Great, thank you. The next question is, would you consider Bel Air to be a permanent supportive housing facility? And if not, do you anticipate that it will need to become one?
That's a great question. We've kept our options open with Bel Air to kind of see how it goes. My guess will be that over time, we'll likely use more of those beds, but we wanted to have flexibility so that going forward, if something changed or we had a nursing home change or there was some different, we could move the beds in different directions. I will tell you the Vermont Housing Trust is very smart about how they do, Champlain Housing Trust is very smart about how they do this. They always have backup plans when they get into these building situations. So that's why initially it's 3 for medical respite and 5 for other, but I do think over time we'll be able to use more of those beds for medical respite, yes.
Thank you. I think, and forgive me if you've answered this in one way, but I think this question kind of follows along the same line. So do these apartments, I believe the Bel Air as well, the 8-unit ones, use a lease, or is it treated like a program? The person asks because of the time limits for the 3 apartments used for medical respite and managing fair housing and landlord-tenant laws.
You want to try that one, Penrose, or you want me to?
I want you to.
So that's a complicated question. Let me make sure I have this right. So so at Harborview, because it's a motel, there's a limit on how long people can stay there. At Bel Air, we've set ourselves an arbitrary limit. We picked a number. We said if we think you can get better within 6 months, it would be a good potential site for you. We really want people going to Bel Air to be able to have a plan to get back to better health and leave, to have some turnover. And Beacon is for permanent housing. So Beacon is unlimited forever, and Bel Air, we just didn't want to put 3 people there and then have no more places to put people who needed transition. So both Beacon and Bel Air were set by us arbitrarily, and there are zoning rules around Harborview. Does that answer the question? I hope it does.
Yeah, I think so. We'll see if they follow up. So so the next one is, what was the community's response to this initiative?
Of course, you've already addressed that to some degree when you talked about engaging the community, but is there more to that story?
I have a little vignette that I think is really pretty nifty. About a year ago, I went to a United Way meeting, and it was with their fundraisers to tell them about the process and the project, and talked a lot about Beacon Apartments, and showed them our video, which is really quite moving. And one of the people on the committee leaned back in his chair, and he said, and he lived in a very nice neighborhood, and he said, I drive by that place every morning, and I have watched those people get healthier. I see them at the bus, I see the one guy on his bike, and their color's better, their posture is better, and I've watched them get healthier. And I just thought that was just wonderful and wonderfully profound about someone who really wasn't looking for that was seeing it and felt he was seeing it in such high resolution that he could comment on it.
That's great. Thank you so much for that. Okay, going back to the question that Steve just answered, there was a follow-up in that just do they sign a lease?
Do they finally leave? So Bel Air is so new, we've just started putting people there.
No,
yes.
Steve, sorry. She asked, do they have to sign a lease, like an apartment?
So for the 5 more permanent ones, they do sign a lease. For the medical respite ones, I don't think so, no.
Okay.
So perhaps, I don't know if maybe we need to circle back. Perhaps you could say a few words about the vouchers and how those work, since people are asking, well, how is, if they're not signing a lease, how is it that they're able to stay there? And that feels like it's about the vouchers. Could you talk about that?
Sure. So when we're discharging people from the hospital to Harborview, if we've determined that's where they should go, some people actually have resources and can pay and go there. But the majority of people need help, and we give them a voucher. They present it to the person running Harborview for X number of nights, and then it's paid for. So they get a voucher for 5 nights or 6 nights or 8 nights, and then they can stay for those nights, and then Harborview charges the medical center off the guaranteed nights that we've purchased.
Thank you. And we just have a comment. This is an amazing program. She's happy to share this information with her community.
Wonderful.
The next question we have is, what did you need to do? So what steps did you take to get all of the different partners to the table?
We didn't really have to. We have a really rich tradition here of working with our partner organizations on a variety of things. And we've been doing community health needs assessments back into the 1980s with United Way, with our federally qualified health center, visiting nurses and others. So really it established the relationships, and that's why, as I mentioned earlier, when we were given the opportunity to invest some of the unbudgeted revenues from fiscal 15, we knew where the needs were. We knew with whom we could work. And Champlain Housing Trust, I can't say enough good things about them. They run a very, very effective program. They have a huge commitment to getting people into permanent housing. They have a variety of programs to really support and engage people so that they can be safely housed forever. And so we knew each other pretty well. We didn't have to go out and create any new friendships. We built on relationships that existed, in some cases, for decades.
I'll just add that the partners were extremely happy to have us come to the table. As I told you before, in 13, this was identified as a huge problem, and we just weren't really ready to jump in at that point in a meaningful way. But once we said we want to be part of this, they couldn't have been more gracious in accepting us in and working collaboratively together to try and address this problem.
Thank you both. So the next one is, do you have any advice for anyone who tries to implement the program on a larger scale?
I would just say that, go ahead, and I'll follow up.
Okay. I think the bit of genius with ours is that we were really looking at what changed. And because we come at it initially from a medical kind of perspective, getting people out of the hospital into safe housing outside the confines of the inpatient setting, we started off saying, what impact is this having on healthcare costs? So we were able to demonstrate very quickly, and frankly, to a bit of surprise, we did not anticipate how much impact even a short stay of 3 to 5 days could have on a person in connecting that individual with supports that he or she needed, or perhaps just having an accountability to someone other than themselves that gave them the incentive to take better care of themselves. So that's what my watchword to anybody with any of these programs is to count whatever you can count. And the challenge with other social determinants, unlike housing, the rewards will be further out. But I strongly advise everybody to count everything you can think of counting.
That's exactly what I was going to say. Track your results. Be very meticulous about that, because if you can show a return on investment, that opens up lots of opportunities to grow programs.
Thank thank you. Did you partner at all with your state Medicaid office or other state partners? Is there a role for states to play in these partnerships?
Well, as the original slide showed, and we did partner with the Department for Children and Families, and our United Way has been a strong advocate for people that need that kind of advocacy with Medicaid. It's part of our Agency of Human Services here, which is also the home for our Department of Health. So there are relationships there. It's been more challenging with Medicaid, and part of the reason, if not a significant part of the reason, that we need to provide an annual subsidy for Beacon Apartments is that some of the care management services that are offered there don't qualify for reimbursement from Medicaid, and it would be great if they could, but we're really strapped right now, and it's unlikely that they would expand to include that.
And the one thing I'll add is, so we did work with DCF, and I will say that our regulators did allow us to use some of that patient revenue overage to invest in social determinants of health. I don't think that would have happened 5 or 6 years ago. They were proud of it. We were proud of it. We promised to measure the results and get back to them. So I think that's not a direct partnership, but it was useful. And I will just say the data that we were able to show from this program we've shown you here helped us to convince them it was a good thing to do.
Great, thank you. We've had a question around issues with patient dumping, and I don't know if there's anything you can address on that, like why are some hospitals, I guess, allowed, essentially?
Is that a term that you're familiar with? I don't think it was in quotations, but I think it's a sort of it seems to be a shorthand for some process that people are.
So a lot of providers talk about having patients show up at their hospital who have social issues or other issues that make them potentially very, very hard to discharge. It's common everywhere. I mean, I've seen some data that in the state of Vermont right now, which is a very small state, on any given day there may be 30 or more patients who don't need hospitalization but don't have a safe place to go for discharge. Sometimes hospitals, small hospitals, will try and move them to the academic medical center just to try and get their bed open, and that people call that dumping. There are no rules or regulations around that, because if the patient is felt to have a health issue and you have capacity to care for them because of EMTALA, you have to accept them. It's not, the good news in Vermont is it's small enough we all know each other. I mean, in the state of Vermont, all the chief medical officers all meet regularly and know each other. So if somebody was doing that, we have a relationship that would allow us to have a good discussion. And when we've accepted someone at the academic medical center and we've determined that they don't need to be here, I can call my colleagues at the other hospitals, and typically they will take them back.
Great, thank you so much, Steve. The next one is, let's see. What factors improve your ability to work together with local partners on specific issues such as housing? What builds those relationships?
I think it in many respects is the community health needs assessment and 30 years of working with community partners. Ironically, in the 2013 assessment, affordable housing was identified as a significant community need. And in our first implementation strategy, we acknowledged that and said, well, we're a healthcare organization, we're a hospital, and we have great community partners, and we know they'll do a really good job on this. And then within a very short period of time, maybe 12 to 18 months, we started talking with the Champlain Housing Trust, and it evolved into the discussion that led to Harbor Place and then now the other projects. So it's people working with people. You just got to know each other and talk to each other. It's easier here because we are smaller and we do know everybody. It's a little harder to hide the bodies when you know everybody. So we do keep each other very accountable, and we're very good about describing our limitations. Even though we're significantly larger than any of our partners, we are a nonprofit as well, and we have limitations. And I think we've been transparent and honest about describing those and looking for what they can do to supplement what we can do.
Couldn't have said it better.
Thank you. The next one is, when the 19 beacon slots are full, do you anticipate still needing more units? Are you looking to expand access?
I know Champlain Housing Trust is looking at least one other site. We do have a commitment in the community to make long-term homelessness only a memory, and to be able to house as many people as want to be housed. It's aspirational. I fear we will never get there, but I think we're very well on our way. We've reduced homelessness in the annual point-of-time survey, I think, by 30% in the last 3 years. So it's an area that the community is definitely focused on.
Thank you. How do patients get from housing to their healthcare appointments? Does the hospital provide transportation?
Penrose.
The housing sites that we've talked about today, they're all on the bus route. So we do provide bus vouchers for people who need it through our case management folks. Steve knows far better than I because of his work with the emergency department, but we do a variety of creative solutions to help people get to and fro.
Great. So we'll just take one or two more. We're winding down here. The next one is, do the case managers on the properties work with individuals to place them or transition them into substance abuse recovery centers?
Yes, they do. They work with them for any needs they may have, everything from getting registered for Medicaid, getting substance abuse treatment, getting a primary care doctor, really whatever the people need to be successful.
Great, thank you. The next one is, have you seen changes in the physical and mental health of your community since implementing this initiative? I know, Penrose, you mentioned a story that other community members have, but do you have any additional perspectives on that?
I think it's the data that we showed you early on in the slide presentation. This is a job that will never be done, but I think we have made progress.
So I want to circle back to the video that Penrose mentioned a few minutes ago. We have put in the chat section a link to the video that she mentioned, and this is a really wonderful 8-minute or so video that tells the story with just really well edited. For those of you who may be thinking about launching a program like this, this is a wonderful way to get people engaged, is to share this video. We didn't have the ability with our technology to do it over the webinar, so we wanted to make sure you could get to that. I want to thank our speakers for all of their thoughtful answers. We did not get to all of the questions. There are many, many questions in the queue. So what we're planning to do is to follow up with questions and answers and provide a link to that where you all can access those answers, including the answers that were already discussed here. Also want to share that the Public Health Foundation provides resources, training, and technical assistance to support your work in population health improvement. And we do this through quality improvement, performance management, and workforce development. We invite you to become familiar with and use our publications, our free resources, our training and technical assistance as your work continues. On the screen, you can see contact information for me, Margie Beaudry, and also for Penrose Jackson if you have particular questions about the program from the University of Vermont Medical Center, as well as some links to other resources that may be helpful to you. Keep your eyes open for the Future of Population Health Awards for 2018, and we want to thank everybody for joining us today.
Thank you, Margie, for the opportunity.
Thank you.
Take care, everyone.